Hello, I'm Dr. Tamara McGregor. I'm an associate professor at the University of Texas Southwestern Medical Center. I work in the Department of Hospice and Palliative Medicine and the Department of Family and Community Medicine. Thanks for being here today. I'd like to talk to you today about palliative care in MSA. Have a couple of goals and objectives about today. I'd like to use a case to illustrate some of the things that we do in palliative care, including the symptoms that we see. I'd like to talk a little bit about how palliative care can help with those symptoms. And I'd like to demonstrate a role for palliative care in goals of care discussions in MSA patients. Usually the first thing I ask my patients is, what do you know about palliative care? The number one answer, never heard of it. So when I get that from my patient and their family, I want to tell them kind of my understanding of palliative care. So the definition loosely is that palliative care is a branch of medicine that's usually reserved for patients with serious illness, serious symptoms, and a need for serious decision-making. Palliative care is appropriate alongside life-prolonging care and treatment. And palliative care concentrates on improved quality of life for patients and families by addressing the significant symptoms and risks ahead, and always keeping in mind the patient's goals of care. The easiest West Texas definition for me is that palliate means make feel better, stuff that we may not be able to fix. Starting the conversation sometimes in this arena is a little difficult because it's often taken a long time to get the diagnosis of MSA. There may be a period of ambiguity between the time that we know what you have and we know what's going on. Patients and families often will find it difficult to consider a long-term prognosis, especially when that diagnosis is pretty new to them. It is important that we have early and effective advanced care discussions to help make the best possible choices with regard to the wants and needs of a patient with multiple system atrophy. A palliative consult might involve something like this. Usually we like to assess patient and family understanding about palliative care and then educate on those issues. We like to then address daily symptoms and help prioritize the treatments of such. We do like to explore the patient's functionality and the quality of life that the patient and the family are having at this time. And then we like to also discuss advanced care planning. This is sometimes scary, but important. And I find in this clinic, in the MSA clinic, patients and their families are already ready to discuss what they want and, more importantly, what they don't want. We do like to discuss medical decision-making. That is, who would be their choice to help with their medical decision-making. What would they want in an emergency, i.e. code status, and what are some end-of-life treatment choices that they may have. And then I usually make sure that the patient and the family understand that palliative care and hospice are related but not the same. Okay, here is our case. Mrs. D is a 67-year-old woman with a diagnosis of MSA for 2 years. She was seen by palliative care during her routine MSA clinic visit. She sees her other providers during this visit, but has not yet met me as part of her treatment team. She's able to answer questions, but has some difficulty with what she calls awkward sounding speech. So she allows her husband to help her answer simple decisions, especially when she's getting tired. She and her husband traveled to Dallas about 3 hours from their hometown in order to see the specialty MSA clinic. Unless they have new problems or she has a new complication, and adjustments can be made in the scheduling. Both Miss D and her husband expressed frustration at how quickly this came on, and at the time, and frustration at the time that it took other specialists to reach her proper diagnosis. She feels that today she feels okay, but she's tired. A little bit on her past medical history. She was diagnosed in 2020. She had had 2 previous years of worsening neurologic symptoms, blood pressure instability, tremor, weakness, and was difficult to come with a diagnosis. Of interest, she has right breast cancer history, which was treated into remission. She has been married 37 years to her husband. 3 adult kids live nearby, and they're very supportive. She also has a history of stable depression, and she has no substance use history. This is a very busy slide, and I put it here because you may be familiar with one or most of these symptoms that we may see in MSA as it progresses. So it may start early with immobility and worsening weakness. We often will see muscle cramping and spasm. Fatigue and poor energy are common. Blood pressure instability and what we call autonomic dysfunction becomes apparent. Later complications may be memory and concentration issues. Depression and anxiety due to the progression of illness and loss of function. We may see swallowing difficulties or difficulty taking oral medications or foods. We may see shortness of breath or strange breathing. Sometimes we see and often see difficult speech and loss of speech, obstructive sleep apnea, and other sleep disorders. Patients may need increased care over time, and we may see things like urinary retention and incontinence, related skin breakdown. I do have patients with MSA that do have pain, which we do address. Frequent turning to resistant infections are common in all neurologic diagnoses, including MSA. And all the while, we may see Parkinsonism and tremors. We may then have risk of aspiration pneumonia. And then we may have the hardest complication, which might be respiratory failure, which might lead to situations where mechanical ventilation would be suggested. I bolded the more worrisome symptoms. We did not see all of these in Ms. D, and they're not intended to be scary, but they are things that I think are common and important. Back to Ms. D. She does have some pain. And the way this slide's going to go is I'm going to tell you what her symptoms are, and then the next slide will tell us what palliative care would opt for or try. So she does have pain. She has intermittent abdominal pain and bloating, sometimes relieved with bowel movements. She has morning joint stiffness, and she takes Tylenol, which helps a little. Muscle tightness and spasticity has worsened over the last 2 years, and she often has to change her position. She does take some muscle relaxant medicines very rarely. She does have a history of constipation. They didn't define it as constipation, but she was having hard, infrequent stools, hard to pass, with straining every 3 to 4 days. And she was not having any relief with softeners and every once in a while Miralax. Her appetite, she describes as feeling full really fast. So when no matter whether she's hungry or not, when she starts to eat, she feels very full. She gets some symptoms of acid reflux, especially when lying down, and some nausea without vomiting. Her mood is depressed. She feels that while medications have been helpful and she has great support from her family, she is feeling more and more down about the physical changes and the functional losses that she's experiencing. So in response to her pain symptoms, we would suggest treating her joints with analgesics. I'm a big fan of Tylenol. In certain cases, anti-inflammatories can be helpful. In more severe cases of pain, especially neuropathic pain, we treat with low-dose opioids. We do like to promote the use of home physical therapy and stretching for muscle spasms. Muscle relaxants can be helpful, but we have to be careful not to make a person too sleepy. In constipation, we always increase their bowel regimen with a goal of a nice, comfortable, soft bowel movement 1 to 2 times every 1 to 2 days. The early satiety, or that early appetite change, we start recommending your favorite foods, those things that taste best, that have a texture that the patient can handle well, that have high impact. Good calories, good protein, good taste, and some sense of enjoyment. We want that patient to really enjoy their foods. They'll eat better if they like their foods. With the depression, we want to increase the support for the patient with maybe counseling, maybe increase support for family, and maybe medications. Additional symptoms MSD has. She has had worsening weakness and mobility. Started with unsteadiness. She now is needing more assist with her transfers and is using a wheelchair because her legs aren't working properly. She's now needing some help with feeding as her hands don't cooperate anymore. She does have dysphagia, which is trouble swallowing. She notices a throat clearing and a little small cough after swallowing thin liquids. She does okay with small bites and soft foods. She is starting to have some difficulty with her speech. It's softer, and she says weaker and more difficult for others to understand. In red, the palliative discussions on this. For weakness and immobility, we may increase and agree with increased physical therapy and physical medicine support. And what we call energy conservation. That is, decide what things you need to do, what are the most important for your day, and use the energy for those most important things with a plan for rest. She does have some dysphagia, which is very frustrating for patients and worrisome. Increase nutritional consults, prioritize those enjoyable foods, and then start to consider the what ifs. What if you were getting where you were not able to take nutrition or medicines by mouth? With the difficult speech she is having, we do have various language aids. I cannot stress how important it is when you start to have or start to see language difficulties to jump on different ways to communicate. Because when we see a change in speech, sometimes it occurs quickly. And I experience a lot of frustration of patients and families who thought they had more time to be able to make ways to talk to each other when speech became a real problem. I also encourage important and early discussions about those communication needs. What are some goals, fears, and what are wishes for care? She also has orthostatic hypotension. That is a feeling of faint feeling when she moves. She goes from lying to sitting. This is a significant fall risk. She does not have any shortness of breath. She is awakening unrested, so she is very tired. She's not resting well. And she is pretty worn out, she said. Her sleep, she's able to fall asleep, but she awakens with stiffness and spasticity, and it's very difficult to get back to sleep. She also is having some urinary incontinence and retention, has had multiple infections, and is now requiring an in and out catheter every few hours. So again, palliative addressing of those symptoms, when we want to increase for the blood pressure instability, we want to make sure that she's seeing an autonomic specialist who can help with devices and medications, medical beds, etc. She does not have shortness of breath, but if a patient of mine has shortness of breath, an MSA patient has shortness of breath, then we try to treat for what's causing it. We try to avoid sleeping completely flat. In severe and end-of-life situations, then in severe shortness of breath, low-dose opioids can be helpful. Fatigue, she's definitely having that. We want to talk about her care needs and see what we can do to make her days better. We may need a sleep study to help with her interrupted and uncomfortable sleep. We may increase medications at night for comfort. And she, again, may need a medical bed or additional medical equipment. And her urinary incontinence, it's important to keep specialty urologist care. At some point, an indwelling bladder catheter may be helpful when the in and out catheter episodes are too uncomfortable, or if they're starting to experience some trouble with skin breakdown. So palliative care definitely has 4 major tenets. We promote shared medical decision making. It's extremely important that the patient is well represented and is well heard. Your physician, whether it be your neurologist or your primary care physician, should be thinking about an annual functional review. It is, how are you doing this year compared to last year? What are some treatment goals? What are your preferences for emergency treatment? Palliative care definitely will concentrate on the functional review. We look at milestones. If there's been a major change or a major event, sudden hospitalization or a sudden loss, we want to talk about where we are and where things may be going so that we can be prepared. We definitely promote honest and thorough conversations. There may be major treatment side effects that we need to discuss and consider. That feeling of loss of independence needs to be addressed, and the quality of life for each day. And we may also want to discuss and talk and help get some increased help for the caregiver. It's important to know that palliative care goes alongside active medical treatment. So a person does not have to be at the very end of life to get palliative care. In fact, the earlier we get palliative care, the better the outcomes. And it actually helps people live longer. It's not uncommon for MSA patients or their families to ask me how long I think they may have. Obviously, that's challenging. My crystal ball is broken. But we have to talk about it. It needs to be a safe environment and a safe space to talk about what we're worried about. MSA is tricky in that it may be indolent and slow, and then you may see a drop in function in a short amount of time. Also, it's challenging because the longer your physician takes care of you, sometimes we become less and less accurate in our predictions and prognostication. I think it's because we get close and we start rooting for that patient more and more, and we make decisions together. And I think it's very hard to recognize when things are changing, when we're very active and involved in that patient's life. Prognosticating does help allow patients and their families to identify some priorities based on how long they might have. It helps patients make informed decisions. It definitely encourages and allows people, especially if we're talking about this early, is to complete advance directives and to designate a medical power of attorney, which we'll get to. That may help attend to legal and financial matters, help us focus on life closure and goals, and to emphasize participation in those things that they love. Find those things that you enjoy and that you want to spend time doing, and let's do less of the other stuff. Again, palliative care aims to create a safe space. There is nothing that we can't talk about. We want to talk about daily concerns and future concerns. We're going to always prioritize the patient's wish, their comfort, and their safety. And we may pose several questions, if not in the first consultation, maybe as we go along. That is, what makes your life worth living? What brings you joy? What is most important to you and your family? And where would you want most to spend your last months as they approach? And finally, what would be an unacceptable quality of life, in your opinion, in your mind? Addressing quality of life with MSA is facilitated better by talking about medical decision making and maybe completion of goals of care documents. The one thing we may talk about is that does the patient have a medical power of attorney? I describe a medical power of attorney as a trusted voice to help make your medical decisions if you're not able to express them. Who do you trust? Who knows you well enough? I do make sure that the person chosen to be the medical decision maker, one, is legally able, and we may need documents, and two, to make sure that the loved one or the medical power of attorney understands that they may be asked to make decisions for the MSA patient, but they they need to remember that they are simply the voice of the patient coming through their own mouth. So even if the medical power of attorney's decision would not be the same as their loved one patient, their job is to honor those wishes and speak for the patient who maybe can't communicate now. Code status is another discussion we bring up. This really has to do with if there was an emergency tonight in your home, what is the plan? And what sort of emergency crisis care would you seek if that pertained to you? You weren't breathing well, your heart wasn't beating well, there was a cardiac arrest, etc. We do talk about full code, which means try all advanced life support attempts versus do not attempt CPR, or what we may call DNR or DNAR. Advanced directives are often called the living will, really pertains to the choice or decision about comfort at the very end of life in the setting of irreversible or terminal conditions or an increasingly poor quality of life. Choices, at least in Texas, or that the patient would either want comfort and all comfort measures, but be allowed to pass away not on life support machines, or they may opt for comfort but remain on all possible life support interventions. And it's not an all or none, it might be all or some. Documents and forms may differ from state to state. Palliative care's role in the MSA patient is to help add to the care of the patient and add to the support for the neuromuscular team, but not to replace the existing teams. We like to serve as a resource for active symptom management and to help prevent complications. We do support patients' care goals, including the pursuit of life-prolonging therapies, but we overall especially emphasize the patient's autonomy, their comfort, their choice, and their quality of life. While palliative care is appropriate at all phases of serious illness, patients who receive early care do receive the most benefit because we're increasing discussions, we're making better decisions, and we're improving their support. I think it's important to distinguish that palliative care and hospice are first cousins. Palliative care came from the concept of hospice. Hospice, which was described in another talk, is to make the patient comfortable near the very end of their time, be where they want to be and get the kind of care that they want, and have the support they need to do that. Palliative care came from the hospice concept, but said, okay, that's a really good care plan. Let's back it up so that if we're getting palliative care, we may improve that patient's ability to continue life-prolonging therapies. So everybody that's getting treatment of any kind deserves to be the most comfortable and have the kind of care they want and be where they'd like to be. As things progress, I may be asked by patients I've seen or their families to start talking about transition of care and at what point when hospice may be better than the type of care they're receiving now. How can you get palliative care? The patient and family can always request a palliative care consult while in hospital. Most major hospitals have palliative care, which was not the case 10 years ago. If you are looking for an outpatient palliative care physician, that's a little harder. You may be able to get a referral from your neuromuscular specialist. You can reach out to the county medical society and look for existing palliative care physicians in your area. Internet searches, there's a website at the end called MyPC Now or getpalliativecare.org. These are two sites that you can look. And you can also look at hospice.org because it may also give some palliative care availability. Most palliative care is delivered in a hospital or via home health hospice in the South and the Midwest, where most palliative care, there is more offerings of palliative care outpatient in the Northeast and the Northwest. But it's regional, and we're trying to expand the availability of outpatient palliative care more to not just be bound to university centers, hospitals, and specialty clinics. We may need to refer to a local hospice if the patient becomes very late stage and if the prognosis is 6 to 12 months or less. And we're always going to consider that medical complexity, what kind of equipment they need, specialty meds or treatments may be helpful. And we may confer with a local hospice to say, what can we do best to get this patient the best possible treatment and care and referral if hospice is where we're going. In summary, most advanced MSA patients suffer from significant symptom burden and can benefit from active palliative care, which can be integrated into care outpatient and inpatient. Patients with worsening symptoms or development of life-threatening complications should be counseled early about preparedness planning, advanced directives, and end-of-life care choices. Patients who receive palliative care in MSA, cancer, other diagnoses do generally live longer and spend less time in hospitals, and they are more likely to have clear advanced directives. In-stage MSA patients and their families, and really not even in-stage MSA patients, benefit from honest, clear conversations about palliative care and transitions to additional care such as hospice as appropriate. Here are some references. There's 2 websites that you can access. And this is me. I want to thank you so much for your time. And I'll be answering any questions whenever we have the live discussion.
Hello, everyone. My name is Deanna Upchurch. I'm the Director of Clinical Outreach Services for Hope Health. Hope Health is an organization based out of Providence, Rhode Island, and we provide home care, palliative care, and hospice services. I have been with Hope Health for 15 years, but I've been working in hospice services throughout New England for the past 25 years, and I'm happy to be here today to present to you on a topic regarding MSA and hospice care, making a difficult decision when the time is right. I come to you today as a professional working in hospice care for over 25 years, but also as the daughter of a patient who lived with MSA. So we have a few objectives today. We're going to talk about all of the pieces of hospice care, the what, the who, the when, the where, and the how. We're going to talk about what is hospice care. We're also going to talk about our interdisciplinary team approach and what the team can provide to not only the patient, but also the caregiver, and when it might be time to access hospice services for a person living with MSA. We're going to review where hospice care can be provided to a person living with MSA, and we'll learn more about that. And we're also going to review how caregivers can access hospice services, including caregiver and grief support when the time is right. So this is the hospice journey also of a father living with MSA and his daughter. And I have described this also known as, if you ever told me I'd be presenting on this topic for MSA Coalition Caregiver Conference, I would have never believed it. My father was initially diagnosed with Parkinson's disease and then ultimately with MSA. In March of 2021, he had yet another fall. He actually had one in September of 2020. So it was just about 2 years ago. And this particular incident in March led to an ambulance being called and yet another hospitalization. So the hospital staff where my dad was admitted had really very little understanding of MSA, but fortunately the neurologist on staff there did. And the suggestion was made for my father to enter a skilled nursing facility. And as we know, this was in 2021. We were in a very difficult time when it came to admitting to skilled nursing facilities with the COVID pandemic. And so the suggestion was made. However, because his mobility had declined and very quickly and considerably, my father was very upset, and he expressed that he wanted to go home. He had been in the hospital 6 months prior in September, and at that time, it was a very confusing and scary time for him to be there because he had to be alone without visitors due to the pandemic. So at this time, in March of 2021, we decided to have him return home with the help of home care services initially. And after just spending a few more days with him at his home, I witnessed some drastic changes in his mobility, his eating, and his sleeping habits. And I called one of my colleagues at the hospice that I work for. So making the decision to have hospice care, and I really want to impress this here to our caregivers, I have worked for hospice for over 20 years. And still, even though I was in this time with my father, having cared for him with MSA for a few years, his changes really did not immediately make me think that he needed hospice care. And so even after all of the time working in hospice care, I still didn't know. I didn't have answers. And I'm a professional that manages many different teams within our hospice organization. We service 750 patients on any given day. And here I was without the significant knowledge that this was the right time. So with the help of a wonderful hospice physician and my father, he was very involved in this decision. We made a choice to be admitted to hospice services and caring for him at home. Having that hospice care team, I have to say, really allowed me to continue to be my father's daughter. And yet I was confident that I still had a full care team of professionals who were able to really make a difference in his life. And that meant everything to me and to him. So where do we die? According to a poll by Stanford University, 20% of people die in their home, but 80% of people share that they admit that they would prefer to die at home. So where do people die? And unfortunately, so many people are dying in hospitals. And this was not what my father wanted. This is not what I wanted. So you'll see clearly why we made the decision that we did pretty quickly. So 60% of patients at end of life die in hospitals, 20% in nursing home facilities, and only 20% in their own private home. But yet 80% of people, when asked, say that they want to die in their own private home. So this is where hospice comes in. And we need to know, what is hospice and what services does hospice provide? Hospice care comes at a time in a patient's life when they are not expected to live beyond 6 months, either because of the disease prognosis or the patient is choosing to reject any life-saving treatments. Hospice care is provided by a team, and part of that team's mission is to support the goal of the highest quality of life possible for the patient. We are always focused on quality of care and quality of life. A hospice interdisciplinary team provides patients living with a neurodegenerative disease such as MSA extra layers of support to help manage a whole range of symptoms. And it provides care to their caregivers as well. We want to keep patients out of the hospital and in their preferred care setting. Hospice services address symptoms such as impaired breathing, difficulty eating or swallowing, limited mobility, pain, and more. You can see how this intersects, especially with the late stages of dealing with multiple system atrophy. In the end, hospice care is vital when caring for a loved one who has chosen to stay home during the last months of their life. So more specifically, what assistance does hospice provide to patients? Hospice patients are cared for by a team of doctors, nurses, social workers, counselors, they're certified nursing assistants, clergy. We also call them hospice chaplains, therapists, and volunteers. Each of these disciplines provide support based on their area of expertise. In addition, hospices help provide medications, supplies, equipment, and additional helpers in the home as appropriate, helping us to obtain a hospital bed and to, daily go over my father's medication regimen was really important to us. And that communication with the hospice team and that constant support was something that really made sure we could keep him at home. I don't think we would have been able to do this at all without the help of the hospice team. They kind of just embrace you and bring you into the fold, and they're there with you for every single question that you have. Some hospices, including Hope Health, of course, we utilize the hospice that I work for because they provide great care. Some of them provide extensive grief support counseling for families after the patient dies, and that is not the standard for every single hospice across the country. So I always encourage people. My background is with a master's in counseling, and I have spent most of my time working in hospices as a hospice grief counselor. You want to select a place that's going to be there for the patient and for the caregiver and the family. Sometimes we have patients on hospice services for just less than a week, but yet we provide support to that family for over a year. So really an important thing to look for when you're selecting a hospice organization to take care of the patient you love and yourselves. Hospice can benefit both the patient and the caregiver. In the case of MSA, we all know that this is a relentless and an exceptionally challenging disease, and that caregiving is 24/7, particularly in the last months of life. It was really incredible to me that my father had such a decline over the years, but when he declined toward the end, it was pretty rapidly. But our last couple of months at home were just amazing to be able to be together. And so it's important for us to select hospice services because they can provide so much support to the patient and the caregiver, both medically and emotionally. When is the right time for hospice care? And so this wheel shows us a variety of areas to look at that maybe help us realize that it might be time for us to consider hospice care. We need to remember that hospice care it doesn't mean that we've given up. It means that, we want to improve some of these situations that we see here. And some of those, the worsening or shortness of breath, the frequent medication changes that are happening. This one was a big one for us. The increasing ER visits or hospitalizations, and particularly during the time of the height of the pandemic, were very scary to my father to have to be alone in the hospital setting. Over time, he also began to have some cognitive difficulty, and he would forget. He would forget that we just had a phone conversation, or even when he could be visited in March of 2021, he would forget that we had visited. And 15 minutes later, he was calling us just as we were getting home to say, how come I haven't seen you today? Unintentional weight loss, recurrent or multiple infections, increased assistance with ADLs, frequent falls, another area that we saw a lot of because of the orthostatic hypotension that is associated with MSA. My dad had a large number of falls and other contributing diseases or comorbidities that may take place with the patient with MSA. So next, I'm going to go over the role of the hospice team members, because I really want you to be able to see what each person's function is on this team and why it's so important to have all of these people involved in the patient's care and the care of the caregiver and the family, because hospice is really a holistic approach, caring for the entire family. And I cannot impress that enough. So as we know, the team includes all of the people that I've mentioned before, including volunteers. My own organization happens to have 240 amazing hospice volunteers, many of them who had family members who received hospice care in the past themselves. So they understand what the needs are of a family when they're caring for someone at end of life. These people all work together to address the patient's physical, emotional, and spiritual needs of themselves and of their caregivers. So the hospice medical director, they have a great responsibility to oversee the care plan for the team. Their first job is to assess, to make sure that this patient likely has 6 months or less to live. And I will tell you that is not always the case. Often it is difficult to be able to admit someone to hospice, particularly if they have a diagnosis of dementia only or just Alzheimer's with no other comorbidities. It's very hard to document to prove that a patient has less than 6 months to live. So when I called my colleague at hospice, I didn't think that my dad, even though he had an MSA, even though he had a history of prostate cancer for over 12 years, even though he had a second malignancy of a lung cancer, for some reason, I wasn't sure if he was ready for hospice, because to me, he wasn't eating as well, but he was eating and has showed interest in eating. He wasn't walking as well, but he showed interest in doing all of that. And everything I knew about MSA, even though I knew he would continue to decline, I wasn't sure if he was ready for hospice. And so my friend, the medical director of our hospice, assured me that he felt that it was time, but he came out and did an assessment anyway. The medical director is also responsible for recertifying if a patient does stay on hospice, if they live past that 6 months, making sure that we've documented that this person is still really benefiting from our care, and that still continues to decline, even if it's just a little bit, even if it's just enough for them to still need that full team of support. So that is certainly their role. They also oversee the entire care team, making sure that everybody is on the same page, working with the caregivers, the patient, the family, and that they provide support to the care team and making sure that they're able to be there. I can't tell you how many times people on the team call the hospice medical director just to say, I want to run this by you, want to run this medication change by you, or that sort of thing. And so they are always part of every facet of the hospice patient's care program and making sure that everything is operating at the highest of standards. The hospice nurse case manager, they are kind of what we call the quarterback of the hospice team, and that they are coordinating all of the patient's care and make sure that they communicate that with the patient and with the family throughout their time in hospice. Our nurse case managers also decide how the resources for our patients and families are best allocated, and they formulate that plan of care for each patient. They also they provide direct care duties, and they might do things like taking vitals, periodically doing some wound care. They may be administering medications, talking about medication changes. I know that our nurse, Katie, was our main nurse, and she would see us except for on her days off or any vacations. She was the person that would come out and visit us, and she would talk about my dad's need for medication for the sleep disturbances that he was having. And she would really assess each time, is this medication working? Should we increase it? Should we decrease it? Should we change it? And she was really very involved with that with us. And that was probably the main component of our conversations at the beginning of my dad's time on hospice. The nurse case manager ultimately also coordinates the care for the patient's caregiver and any other family members that they may need some counseling or other support, both before, during, and after the patient's death. So it is really their role to coordinate the care with the hospice social worker, grief counselor, and any volunteers that might be involved with the patient and family. The hospice certified nursing assistant. I always say that these are really if the nurse case manager is the quarterback, these are the running backs and all the people scoring the goals. And I mean that in a loving way. You know, I use football as an analogy. My dad was a big New England Patriots fan and a New York Yankees fan. And he and our CNA, Erica, really connected on those two points. And she really gained his trust and his respect. And they had a great sense of humor together when she would come in to help with everything to do with his ADLs. The CNAs are really important to the overall care of the patient. I feel like they see the patient more frequently than anyone else on the team. Our CNAs came in to start just 2 times a week, but definitely increased over time to the point where we're up to about 5 days a week. And they would even come on the weekends if we needed them to. It's the CNA who helps the caregiver give the patient showers and baths. They clean and dress any wounds or open sores, and they help keep the patient's immediate environment as clean and orderly as possible. And a joy. Toward the end of his life, even when he wasn't able to communicate, Erica would come in and she would talk to my dad as though he was responding to her, and just tell him about the weather, talk to him about sports. And sometimes we could see the little smirk in the corner of his mouth. The CNAs who rotated through our house for the months that they served us, they did a really good job of being my right-hand person. Last but not least, the supportive services, the hospice social worker, chaplain, and volunteers. Social workers can help patients and their family to navigate planning for end-of-life care. They understand their treatment plan, and they want patients to be vocal about their needs and families to be vocal about their needs. They help with a lot of things. Any family stress, any financial stressors, helping families to overcome any crisis situations, and they can even direct them to other support services, especially funeral planning. We didn't even think about it. I've worked in hospice all these years. We've had a lot of discussions about death and dying over the time in my family, but we never planned a funeral. I think it was just something that particularly my parents weren't ready to do. And there came a time and with the help of the social worker, they were ready, and they did have some incredible conversations, and that included some tears, but also some humor along the way. My dad had such a great sense of humor, so that helped. Hospice chaplains, while my dad was not a religious man, hospice chaplains always meet a person where they are. So whether they have a deep faith in a particular religious background, they will meet families there. And they will also meet patients and families if they don't have any religious affiliation, just helping them to kind of work through any spiritual struggles they might have, or even if there's none. I know our chaplain really just talked with my dad about how did he maintain a sense of joy, even though he had been through so much physically. And that was an incredible conversation that I also stepped out and allowed privacy for, because that was my dad's conversation to have. So, but he really liked Dennis, and he enjoyed his visits and his conversations with him. And our hospice patient care volunteers in hospice can do so much. My dad had a volunteer who was able to visit a few times a week and sit with my dad, and they talked, they were rivals when it came to baseball teams, and they talked about football together, and they had a mutual love for war movies. So they used to put on a war movie into the into the DVD player and watch something together. And it allowed time for myself, my mother, my sister, for all of us to go out and grab a lunch, run to the grocery store quickly and not have to worry that my dad was either alone, which we wouldn't have left him alone at that point, but he had somebody there with him. We didn't have to worry about his safety. Our volunteers also in hospice, I know at least at the hospice where I am at Hope Health, they serve as co-facilitators for caregiver support groups and grief support groups. They run errands for our caregivers. They can go to the grocery store. They can pick up other items at a store for a family. We have Reiki volunteers, pet therapy volunteers. There's so much that our volunteers can offer. And it really helps the family. If there's any kudos that we get from families, it's often because of our volunteers. And last but not least, our hospice grief counselor and our bereavement volunteers. So the grief counselor can meet privately, usually with individuals. Medicare, there are Medicare conditions of participation for any hospice, and Medicare does require that grief support services are offered to a family for up to 13 months after the loss of a patient. What that bereavement support looks like varies from one hospice to another considerably. I am fortunate to work for a large nonprofit hospice, the second oldest in the United States. We really have a huge commitment to grief support for our families. We feel that this is something that not only we need to do, but to do it well. And so we provide grief support care to our families individually, in groups, and there are many grief support programming, children's camps, adult retreats, etc. Our bereavement volunteers are volunteers that are specially trained to assist us in those areas. Now, frequently asked questions. Just go through these. These are some of the things we're asked. How does hospice manage pain? Our hospice and nurses, they're up to date on the latest medications, devices, alternative therapies that work to approach pain and symptom relief. And so in addition, we might have physical and occupational therapists and other therapies that might be helpful, nutritional counseling, art therapy, music therapy, etc. There is more than one way to manage pain and other symptoms, and we try to take that holistic approach. It's always the goal of hospice to help patients be as comfortable and as alert as they desire to be. By constantly consulting with the patient and the caregiver, hospices generally have been very successful in reaching that goal. I get this question a lot, and I thought it was important to address it. Is it more difficult to care for a dying loved one at home? And this is my honest answer here. It's never easy, and sometimes it can be really difficult. At the end of a long progressive illness, especially like MSA, nights can be very long, lonely, and scary. And they were. It can be emotionally draining to administer pain control or anxiety medications to a loved one that are for comfort purposes only, when you may have spent years, months, making sure that they've taken their medications to get better or to maintain their health. This was the change. For me personally, that was very difficult to go from administering Cinemet to my father with the hope that it would improve his situation to end up changing to medications that were to be comfort measures. And knowing that the medications were addressing his symptoms, yes, but it's a stark difference for a caregiver to go from one to the other. Fortunately, hospices have staff available around the clock to consult with the family and to make night visits as appropriate. And I will tell you, I called our hospice, not just because I work there. I would have done it no matter where it was. And I call them often. They were my lifeline throughout this experience. Does hospice do anything to make death come sooner? Hospices do nothing to speed up or to slow down the dying process. And a great analogy is just as doctors and midwives lend support and expertise during the time of childbirth, hospice provides its presence and specialized knowledge during the dying process. There are even, just like there are birth doulas, there are now death doulas. And that is another area of studying death and caring for people at end of life just as gently and beautifully as we do when they come into this world. How is hospice care paid for? Hospice coverage is widely available. It is provided by Medicare nationwide and by Medicaid in some 42 states, and by most private health insurance policies. When Medicare eligible patient receives services from Medicare approved hospice, Medicare pays almost the entire cost. And these are the areas that are generally covered. I think it's important to remember to look for a couple of things just personally, my own personal feeling on this is look for a Medicare-approved hospice. Most of them are. And so that most things will be covered. I don't think my mother's gotten one bill for anything from my dad. And the other thing is look for an organization that also provides care for the family, caregiver support and grief support. Very important. So ultimately, why would we choose hospice? Well, in our case, caring for my dad with MSA, we had a lot of reasons to choose hospice. We had guidance regarding our goals of care for him. There was a focused treatment of his symptoms, what he needed each and every day. There was definitely a reduction in hospital visits after March of 2021. He did not go back to the hospital. ER visits and urgent doctor visits. We had incredible emotional and spiritual support. My dad was very surprised at how much he enjoyed his time with the hospice chaplain. Increased quality of life. We were able to be his daughters, and my mother was able to be his wife and give him what he wanted when he wanted it. I remember his craving for Johnny cakes, and we ran out and got Johnny cakes and brought them home to him, and he enjoyed that meal so much. Coordination of care and communication with patient's physician. We had the access to the physician, again, not because it was my place of work, but because that's the right thing for any hospice, is to make sure you have access to their medical director. And the professionals were on call 24/7 to help us if there was any crisis. And as the days went on and as the time went on, I called more frequently with questions, particularly when it came to medicating my dad toward the end of life. Hospice founder Dame Cicely Saunders, her famous quote, "You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die." And that is the most beautiful thing. So not only to work in a hospice am I proud to be able to do this work, but the most proudest moment of my life was caring for my dad, receiving hospice care after years of enduring all of the difficult pieces of MSA. And there he is. My dad was 74 at the time of his death. And so he was still young, in my opinion. And I'm just very grateful to be able to have done this presentation, both as a professional and as a person who was caring for their loved one. And I thank you for being here with me today. Thank you for your time. And I look forward to meeting and speaking with anyone on our panel that is upcoming.